I'm Dr. Christos Apostolou. I'm an upper gastrointestinal, pancreatic and liver surgeon working at the Sydney Adventist Hospital. Looking at the anatomy of the gallbladder, biliary tree and the pancreas, this is the gallbladder here with gallstones, and it is connected to the bile duct, which is a little bit more prominent if I turn this example over, going into the pancreas. And the concern is that if we leave gallstones untreated, not only can they cause strife in the gallbladder itself, with gallbladder wall thickening, cholecystitis and other issues, they can also travel down the biliary tree and affect the pancreas, and you can have pancreatitis, which can be life-threatening. The difficulty is we can never predict when this is going to happen, and unfortunately it can have a very rapid and fulminant course. This always requires hospital admission, even if it's just for observation and monitoring, and it's important to try and work out the severity of the pancreatitis, which may warrant intensive care admission for quite some time. So when patients do have symptomatic gallstones and there's any evidence of pancreatitis, we recommend prompt gallstone removal. And if there are any gallstones in the biliary tree, the patients may require a particular endoscopy called an endoscopic retrograde cholangiopancreatography, which we do to remove the stones from the bile duct. Regarding diagnostic tests, the first step is almost always an ultrasound where possible. It's got a very high sensitivity for gallstones in the gallbladder. It's obviously radiation free and quite well tolerated by all patients. If there's any concern about pancreatitis or any shortfalls of the ultrasound, we proceed to a CT scan, which requires intravenous contrast. So there's certain patients which may not have that. Likely the gold or platinum standard would be an MRI scan, of which we're fortunate to have high technology at the Sydney Adventist Hospital, which can provide a radiation-free diagnosis of gallstones in the gallbladder, biliary tree, and also look at the pancreatic duct. So it gives us a lot of information very quickly. All patients will receive intravenous antibiotics when they're admitted to hospital with a gallbladder issue. Obviously, it would be pertinent to know any underlying allergies that we need to avoid. The patients will receive intravenous analgesia, which is pain relief, and then we'll proceed to the management pathway. In certain cases, if the patient's unwell with severe pancreatitis, we may need to delay the cholecystectomy once the patient recovers, often in the same hospital admission. Commonly, these patients can spend 3 to 4 weeks in hospital, which will reflect the severity of the attack. Most other patients, when presented with acute gallbladder problems, the most efficient way to deal with it is to arrange next potential list removal of the gallbladder, which is elective cholecystectomy. Obviously, the procedure does carry certain risks, and it's important to be performed by an experienced surgeon in an appropriate center with adequate resources.